used to very tough, hard conditions in everyday clinical life. So I'm sure we will manage to discuss clinical cases in these conditions. So the aim of this CTG roundtable was, when we first thought about it, was to learn from existing CTGs and agree on the likely underlying pathophysiology, which is sometimes is not possible, and it's quite challenging, and people disagree a lot. Sometimes they get very emotional on defending their ideas. Because normally you are not. Because normally you are not. And, well, but I think what I would like you to ask is to, in a comprehensive way, for people who are not clinicians, to show key characteristics in specific CTGs that automated algorithms can actually aim to detect and increase the clinical capacity to predict or to prevent some, some prenatal less positive outcomes. Okay, so let's start. In this first case, which is a case that was chosen by Diogo, I will present it. So it was a preemie-gravida, 39 weeks plus 1 day, uneventful pregnancy. Brain membranes were ruptured 30 minutes before, contracting every 8 minutes. VE served, well, it was first stage of labor, cephalic presentation, normal CTG, and believe us, it was normal. Okay, we were just cutting the presentation a bit so that we can actually do this in a feasible way. 2 hours later, normal CTG, epidural analgesia was on, and oxytocin started at 2 milliunits per minute as a way of accelerating labor. 6 hours later, cervix was 8 centimeters dilated, so it was actually accelerated, this labor. Had a less -1, oxytocin at 12 milliunits per minute. There was a big fetal heart rate signal loss. There was a question of tachycardia or not, and stent was started at this time. And this was the CTG. Diogo, do you want to comment on this CTG, please?
Yeah, it's not sure that people can see the actual scale, because this is
1 centimeter.
110. So the white part would be the normal for the FIGO guidelines.
1 centimeter per minute.
This is at 1 centimeter per minute, especially for you, Brian. So it looks like there's tachycardia at the beginning. We also have the stand, but it was started here. So according to what the stand guidelines say, if it's not really normal at the beginning, you should not pay a lot of attention to the stand, because it could be changed right from the start and it doesn't actually identify any of the events. But with time, the variability seems to be relatively normal. So perhaps we can trust the stand information in this case. But there seems to be tachycardia and repetitive decelerations. The contraction signal is not very good. Should we go on to the next one, Ines?
Yeah. Do you want to comment on the maternal temperature and?
Oh, yeah, it's up there.
Yeah, I know. But okay.
Sure, no, it's up there. 38.4. That's true.
Would you do something? I mean, regarding this tracing?
No, well,
sorry, Barry. Let me just. Sorry. just before. So, would you do regarding this trace?
Yeah.
Would you do something in terms of the management?
The lady was on epidural, and you get a lot of hyperthermia on epidural. Sometimes it's not related to infection, and Austin was making the point that it's risky anyway. But you can, with epidural, you lose the control of the thermoregulatory of your center. So if you lower the room temperature and you give paracetamol, many of the times you'll get a normalization of the baseline, and I think that was done here.
Okay, Barry,
The only point I want to make, one is the baby is clearly recovering from an event that we don't see. Okay, so that original tachycardia, you can make a story, but that was probably a deceleration from which the baby recovered, and then recovered in a deceleration and would come down to what is reasonably its previously normal and a stable baseline, and now with contractions. And reasonably you can time the contractions simply from the timing of the individual decelerations. And notice that if you drew a line, certainly that this would be a stable heart rate, moderate variability, and intermittent decelerations. Pushing, probably not. Yes, probably not. So that's what I would.
But alternatively, the tachycardia could be just related to the temperature, not to previous deceleration.
No, but you wouldn't expect it to come down that quickly. You're now down in what?
It's in about 20. No, it's about from here where the paracetamol was given till there it's about 25 minutes.
No, you're right. But I'm just thinking that the original tachycardia, and you see it comes down, and first there's a deceleration. So my sense would be that there was I don't know that it's important. The important point is that it recovers to something manageable and stable.
Okay.
Yep.
Thank you, Barry. Austin, would you, regarding maternal pyrexia that you were talking to us?
Well, first of all, I have a slightly different interpretation to the ones offered by Barry and Diogo. I agree with Barry that something had happened which we don't know about. The question is, what is it? Now, if Diogo's account of the original CTG is correct, that it was normal, we've got two possibilities. It's either there were antecedent decelerations that provoked this increase in baseline fetal heart rate from a normal baseline, in which case this is likely to be an evolving hypoxia process, or actually this is fetal response to ongoing chorioamnionitis. It's got to be one of those two. Now, if there were no decelerations, we're left with one option, and that is likely that this baby is responding to ongoing infection. I made the point in the lecture that babies don't necessarily run tachycardia because mom is pyrexic or
Sure.
because mom is, So for me,
Or has chorioamnionitis, actually.
exactly, for me, the biggest concern is that this increase in baseline fetal heart rate may be a consequence of ongoing fetal response to infection. Yes.
Right, okay.
As I understand it, the baby is at term.
Baby has a turn.
Yeah, so I wouldn't be
No
expecting.
complications
Correct.
so far as we know.
Yeah.
Based.
And the mother didn't have a lot of risk factors
No.
for chorioamnionitis because ruptured membranes was
Yeah, we can just.
like 8 hours, well, maybe 4 hours. I can't remember.
Except that
Plus,
you don't need rupture of
Yeah,
membranes.
Okay,
for-
I agree.
Yes.
Yep. Okay.
You don't need rupture of membranes for.
Is the rate higher than it was at the onset?
Yeah, because it was completely normal tracing and then signal loss, and so it was totally normal tracings before, except for the last part of the previous tracing that led to the internal monogene stand.
I have to say that those decelerations are not deep and vigorous enough for me to think that they were the ones that provoked the ones that provoked the baseline tachy. So I will look for the causation somewhere else.
The decelerations are new.
let's listen to neonatologists.
Sorry. Commenting on the choice. But my question is more about that distinction between non-infectious fever or pneumonitis. I think that's crucial, and I'm worried that by treating the symptom and not dealing with the possible etiology, you might be covering up the clinical presentation of the potential infection.
Yeah. I take both of your points, but the thing is, you get a lot of this when you do a lot of epidurals, as you do in Spain and Portugal. So if we were to react thinking about infection in every single case you have a mild tachycardia, I think we would overreact. In many of these situations, even without giving paracetamol, just by lowering the temperature of the room, if you have air conditioning, you get a normal baseline after that, 30 minutes after that.
Would you start antibiotics?
Can I just come back?
Sorry.
Can I just come back to Anna? To the best of my knowledge, there are no antibiotics on the market that actually cross the placental barrier in sufficient concentrations to eradicate established clinical chorioamnionitis. So although we give antibiotics in clinical practice, the aim actually is to sort of contain the infection in the fetal compartment and protect mom to some extent. But the real management the core of the management for chorioamnionitis is delivering the baby.
Yeah.
Yes, that's. So I come across cases where people have administered antibiotics and then fall back in the mistaken belief that because they've given antibiotics, they're curing the chorio. And actually, the longer the baby spends in that environment, the weaker and sicker they get and make the problems worse for when they come to you.
Right. Fair enough.
Would you, Austin? Would you ask for some labor workup from blood workups? In this, would you ask for blood tests in the mother at this point, or no? It doesn't change your clinical.
No, again, the guidelines will say do the blood work, but labor, as you know, is an inflammatory state.
Yeah.
So things like your in fact, your inflammatory markers become invalid. But more importantly, the question you're asking is whether this is potentially a vertical infection that has gone from the mom to the baby. Now, that's a very rare situation to find in labor.
Mhm.
In about 10, 12 years, I've only identified 3 cases. So they're not very common. But the guidelines say you should do blood cultures and things.
Right. Okay. Just for people to be aware of what the guidelines are. So let's move on. Here we have this event. These are topics for discussion. Diogo, would you like to comment on this event, please?
Yeah, well,
Think of what it is.
this is where I think, I mean, it's important to give it a name. The way we deal with it is another story, but according to the FIGO guidelines, if it has more than 3 minutes, it's a prolonged deceleration. So you don't have to look for any other characteristics. It's 3 minutes, it's a prolonged deceleration. What I think is quite evident is that it recovers quite quickly and it goes on to have normal variability. So where I would probably be somewhat worried in the middle of the deceleration if I didn't know what was going on after that, the fact that it recovers quickly and regains variability is, for me, relatively reassuring. So I carry on monitoring in spite of having just one prolonged deceleration. It seems to be occurring with a contraction. For some reason, they're not monitored before, although there were contractions. Otherwise, you wouldn't get the deceleration. But so I would readjust the TOCO and carry on monitoring.
Right.
Is that the maternal heart rate at the bottom?
No, this is ECG.
Oh, right.
This is ECG.
But even with ECG, we can sometimes.
Oh, yeah, but not for 3 minutes.
Yeah.
No.
Okay.
I was wondering if there was anything explicit in the EGO guidelines about maternal and why you would say it's not.
Well, there is, but this because it's with the scalp electrode. All of this is with the scalp electrode to get the stand signals. Yeah.
Okay. Very. Would you like to?
I think that contraction seems a little unusual in its length and amplitude compared to the rest. Whether there's an examination or something with it, whether she's test pushing. Clearly, this is vulnerable presumably when she's going to push, and you need to watch out for that.
Right.
The baby looks like it's going to recover.
Right. Austin, would you like to add something?
Yes, I agree with both comments. The only thing to add is, have you got a point?
Yeah.
So I agree. I'm reassured, as Diogo said, by the recovery and variability. But actually, this contraction is gigantic, without any doubt. And it seemed to be the reason for the deceleration, just on the face of it. But the other thing that surprises me is, if this is ECG, as it seemed to be, there is a sequence there. If that is fetal heart rate, why aren't there crosses here?
Why are there no crosses?
Yes, because the baseline fetal heart rate here is roughly, is that 100?
And it's quite stable.
Yeah, that's
as well.
100. That's 110.
Yes, so I would expect at least 2 crosses here, at least. And there are signals here suggesting that if this is due to the electrode, I will expect some crosses here, but they're absent. So it goes back to your question.
Yeah.
Whose heart rate is this?
It can be. It can be.
There would be a
Exactly.
serious question.
Exactly. But given what we're looking at, even though it's an electrode, it's still a valid question to ask, because there's a discrepancy between what the display is showing us and what the ECG characteristics are showing.
But then, Austin, then
I
you do
agree with
get
that.
back some crosses here, still in the deceleration.
It is that 1 minute gap I'm interested in.
Yeah, that one.
Because
Sometimes you don't get signal quality that's good enough for it to calculate the TQRS ratio. So
that may be true, but if you put it in context, we're dealing with a fairly large uterine contraction. We're dealing with a pronounced deceleration, and you can't explain loss of signal. I think it's a valid question to ask.
Yeah, I think so too. I agree. Yes. Yes.
Okay. I've seen a lot of maternal recordings like this one, even when a scalp electrode is used. I've been court expert in one case with 2 hours that were considered fetal heart rate using stent, and it was maternal heart rate because the baby was dead. And the tracing, well, was it was very difficult to distinguish, because the pattern was like a fetal pattern. Something like this: fever increases the maternal heart rate, so the maternal heart rate becomes more similar to the fetal heart rate, and decreased variability. Okay, so I agree with all the considerations regarding the pattern, but well, for me, it's very likely that it is a maternal heart rate pattern, and one of a good reason to support it is what Austin said. And please tell me, because maybe you are better than I am. If you look at the ECG waveforms, maybe you can distinguish. So if we have access to the waveforms, we can look at this, and this is fetal or this is maternal. Okay, so yeah, you can answer to this question if you look at the morphology. Okay, so my point is, when we use electrodes, the likelihood of getting maternal is much lesser, but it can be, and for prolonged time. Okay, my message.
what
you,
happens
Thank you.
is
Very
that,
good point.
I'm sorry,
Yeah, sorry. Yeah, very sorry.
you can change the cardiac axis of the baby first of all, during a contraction. Who's done that? Somebody here? Yeah. That a contraction changes the vector. It also can change dramatically the noise ratio between the fetus and the mother. So if you have a high fetal signal and a high maternal signal and a low fetal signal, even on an electrocardiogram, you can see it.
Just to say that I've seen many cases of prolonged maternal heart rate, or many cases, not many cases, a few. But for temporarily, unless I don't see the reason behind it, unless you have a scalp electrode that becomes attached to the. Sometimes you put it in the cervix and it gives you maternal heart rate. If the fetus is dead,
there is no electrical signal from the fetus.
Yeah. The only thing I can see is if the scalp electrode is not completely in the scalp, but becomes in contact with the maternal tissues, or if the fetus is dead, which is not the case.
So it's not dead, it has a reflex arrest, and it disappears for 3, 4, 5 seconds, and
For me, that's not very relevant.
Okay, thank you. Anna, do you want to add something? Okay, let's move on. Thank you. Very relevant discussion. I'm sure everyone agrees with that. This is the continuity of the tracing. Diego, would you like to add something here, or shall we move on?
No, I just want to say that the baseline seems to have gone to relatively normal values. It's around, 150? What, in this room? It looks normal. It's got some accelerations. It's got normal variability. It's got some decelerations. Again, the TOCO is terrible, and nobody has done anything to readjust it, which is something we see very often because people are busy with other things. And this,
It is a TOCO as well.
it's a
No
TOCO.
inter. Yeah.
Yeah.
This is TOCO.
It's all TOCO.
the other thing is
That's important, but sorry, we'll assume that mother can move, or if you don't move the TOCO for a while, normally you stop registering contractions.
you always want to look at what's below, in this case, the TOCO channel. And if you will look at those accelerations and then drop your eye to the TOCO channel, even though they're inverted, you can see a one-to-one relationship between an event on the contraction cycle, on the contraction channel, and the obvious acceleration. But they're clearly a one-to-one relationship between those events. And that's what you're here to do, is to find the relationship between those two.
Fine. Austin, would you like to comment on this
So
relationship?
I've got one question and then one comment. And my question is, does anyone know what the mother's baseline heart rate is?
That's one of the major questions here, especially
Okay, so
after our discussion that we had before.
If you go 2 frames back or 1 frame back, next one. Yes. I find it surprising that a fetus will switch from this state within a short period of time. Now, if you go forward again, forward again. Yes, to this state where it's actually demonstrating, accelerations.
Yeah.
Those 2 settings in the same labor, in the same fetus, within a short period of time, just seem implausible to me. So I think I'm with Barry on this one, that actually those changes exhibited by the TOCO may actually be correlating with. And if we knew what the baseline maternal fetal heart rate is, this may well be a maternal heart rate tracer. Because a fetus that exhibits a trace looking like this is unlikely to be the same individual, half an hour before that showed it. Labor is an escalating process. The fetus doesn't get better.
Descalating process.
Yes, the fetus doesn't get better as labor escalates, if that makes sense. So for me, that would be an alarm bell. I'm not making any conclusions now, but that would be an alarm bell, particularly if mom is hot, if baby is already tachycardic, if you went from a normal trace to what we're looking at. I think I'll be asking more questions.
So shall we agree that we would monitor mom's heart rate?
I'll be asking
Definitely.
what is the mom's heart rate to start?
Okay.
Well, I can tell you it's normal. I don't know what it is, but it's normal.
Right.
So that was, we checked that. This was many years ago here in Porto, and it was normal.
Well,
So
that comes to
we
that
didn't-
comes
we
that
didn't
comes to me
register
that comes to me
until-
as a surprise if she's as hot as 38.5, and then it runs a normal heart rate. I
well,
work
normal at this stage, not before. So it's something like 1 hour after that initial period.
Well, I would still be asking the same question for two reasons. One, sometimes mom's heart rates are derived electronically. And I have been a victim of being misled by some of those electronic things, where a mom's heart rate has been the same until one of the midwives put her fingers on her pulse, and then we ended up with almost twice the value that was recorded. So I think there's enough on the trace to make me want to just review the whole thing again. I just find it difficult that a mom will be running temperature that high and then retain a normal baseline heart rate.
But maybe it's the setting, because here the setting here is we have a lot of epidurals. It was something like 94% when I left 3 years ago.
That's
And the temperatures are hot.
Yes.
Not like in London.
no, it is also hot in London.
Okay. Sometimes.
Yeah.
So we have a lot of of maternal temperatures that go up.
Yes.
Sometimes we don't measure for a long time,
Yes.
and the only signal we have is from the baby getting tachycardia.
Yes.
And if we revert that with the air conditioning and with the paracetamol, I'm not sure the paracetamol is needed, you get actually a normalization of the tracing.
Yes.
We in this setting here in Portugal, we have a lot of those.
I don't disagree with any of that. The point I'm making is, faced with this sort of scenario, I want to unpick each and every of those parameters to just make sure that it is what I think it is. Otherwise, I'll be asking further questions. I agree with you in terms of the frequency of fevers related to epidural. In most, Western capitals, that's roughly what it is. 95% of fevers in labor will be down to epidural, which is why I was making the joke about what happens in my homeland.
All right. Shall we continue then? Yeah?
Maybe when the baby's born.
No, Anna, please. No, please. Really? Okay, sorry. Okay, so, yeah, of course.
In the beginning, when you saw the heart rate go down and you decided to use STAN, but you also saw a trace that was not the best of traces, did you do fetal blood sampling?
No, because we don't use it. We stopped using it when we introduced STAN back in 2001, and before that we weren't doing a lot of them anyway. So only a few people were doing it. So no, we didn't. The alternative is to wait and to see if the CTG is normal, has normal variability, normal accelerations, and that was the case. So we feel no, we didn't use it.
I will add on just to pick up on the question he asked. I think if the fetal heart rate variability is normal, the chances that you're going to get an acidotic result is exceedingly small. So for that reason, I won't do one. Secondly, if, as we think here, there may be infection playing a role, you could easily be positively misled by, a near normal result and think all is well. And then that, encourages you to press on with it. So I think in this situation, I wouldn't, it's a good trick to have, but I wouldn't use that trick on this occasion.
All right, Anna, do you want to, are you happy or to, yeah? So then the trace is this one. At this time, we performed vaginal examination, so cervix fully effaced, and it was fully dilated as well. It's fully dilated. Yeah, it's fully dilated, exactly. So beginning of second stage of labor, had at +1. These are topics for discussion. What would you do, clinical colleagues, in this situation? Stop oxytocin, administer O2, crash cesarean, give salbutamol. Barry, you are with the microphone. Do you want to start?
The issues for me, I would obviously I'm trying to avoid the crash, but I'm not going to try to avoid the crash at the expense of continuing deterioration of the fetus, and so I'm going to prepare for a cesarean section. I'm on my way to the delivery room, and I am turning the patient on her side, and I am going to do a pelvic examination, see if I can either feel the cord, and if I cannot feel the cord, I'm going to gently elevate the baby's head to take whatever pressure off the head that I can. And I'm going to watch the effect of those maneuvers, and to the extent that there is no effect, then I'm going to do a cesarean section.
Right. Thank you. Diogo.
Yeah, well,
I would also stop oxytocin. But that's not.
Yeah.
That's not.
Would you administer oxygen, by the way?
Uh,
On your way to...
The answer is I'm not. It's not clear that it's going to work that fast, if at all. The mechanism. What do you think the mechanism is? The contraction looks like it's going to end on its own, and once again it's this unusual contraction, sustaining the deceleration that we do have. In all fairness, you worried. The head has been so high. You're worried about it coming down, trapping the cord. So by all means, terbutaline, but you're doing this on the way to the delivery.
All right. Joe?
yeah, well, I think it's got about 5 minutes of a deceleration.
1, 2, 3, 4, 5.
And it looks like in the end, it's the variabilities in the last minute is decreasing in the deceleration. So I would definitely think that there is some mechanism that's leading to hypoxia. Again, I'm a bit worried that the contractions are not really monitored appropriately, so there's only what looks like maternal pushing. I'm not really sure. So fully dilated, head at +1. If she has conditions to do an instrumental vaginal delivery, then we start considering that hypothesis. The thing is, if you start doing an instrumental vaginal delivery after 5 minutes of a deceleration with reduced variability at the end, and if the vacuum or the forceps takes 5 or 10 or 15 minutes, which sometimes it does, you may come up with an abnormal outcome. So for me, particularly if I had the notion of the frequency of contractions, the thing is not only to stop oxytocin, which I think should have been stopped maybe 2 or 3 minutes before, because it takes 5 or 6 minutes for the full effect, because it has a half-life of about 6-7 minutes. So stop oxytocin definitely probably earlier than the 5 minutes of deceleration. Oxygen by mask, and I don't think it makes any difference, maybe to the obstetrician, but oxygen to the obstetrician, but not to the mother. So I would give some sort of acute tocolysis agent and wait 2 or 3 minutes to see how that, if there was some reaction to that.
It's not stopping the progress. Is that true?
You know, if I had excellent conditions for vacuum or forceps, if I was really sure that, you know, that the baby was not too big, the maternal pelvis was okay, it would be quicker to do a vacuum or forceps. But if that was not the case, salbutamol and waiting a little bit, getting a normal tracing, and then asking the lady to stop pushing again, or maybe doing the vacuum at that time. If I felt very unsure, that would be the way I would manage this
Yeah.
situation.
Thank you, Dirk. So you would manage this as an acute event here and try to reverse.
And try to reverse it. Yeah.
Okay, fine. Thank you. Anna, please.
What do you think is happening? Do you think with the limitation that contractions are not being picked properly, do you think the mother's contracting too much, or the baby is not tolerating rather normal contractions as you would expect?
I think the mother's contracting too much, but that's because I remember the case, but it's not there. And I know, you know, I've excluded all the other non-reversible causes. So with the vaginal examination, I've excluded cord prolapse. She doesn't have a previous cesarean, so it's very unlikely, and she doesn't have any bleeding. Very unlikely that there's a uterine rupture. So if I find something that's non-reversible, definitely get the baby out as quickly as possible. If it's too many contractions, which I wasn't present, but they told me that was the case, then, you know, giving salbutamol it would be probably the best way, and waiting for a reversal for 2 or 3 minutes. While at the same time having everything prepared for a crash cesarean section if needed.
Yeah, because we had already 5 minutes of deceleration. Austin, do you want to add something to this?
So again, one question and one comment. Is the lady pushing at this point?
The lady was pushing, yeah.
She was pushing at this point.
Yeah, but not...
Right.
Well, there was a vaginal examination, so people were trying to figure out.
Yeah, if the... Yeah.
Right, okay. She wasn't actively pushing at this
It
point.
was not
Okay.
actively pushing.
Okay. So again, I'm not totally convinced that that heart rate there with acceleration is necessarily fetal. But let's assume that that's what it is. If that's the fetal heart rate and those accelerations are genuine, I'll be very relaxed about the deceleration.
Okay.
I cannot see a situation outside of what Diogo said that the main sort of potential obstetric catastrophes have been excluded. So she has never had a cesarean before. There's no cord prolapse. She hasn't got a pool of blood between her legs. I can't see a situation where a fetus will transit from a CTG looking like that to one that needs a crash cesarean section. So you can take out C from the list.
Okay.
Barry and Diogo have already made the point that oxygen, that's useful to the obstetrician, so you can take that one out as well.
Yeah.
I agree with Diogo that the oxytocin, you know, in fact, the more labor, the further labor advances, the less oxytocin that you need. So I think if it hasn't been stopped at that point, I would. I personally would wait to see the impact of stopping the oxytocin on the CTG pattern before deciding whether to give terbutaline or not give terbutaline.
Right.
But actually, if that is genuine fetal heart rate and is dropped to the level we're looking at with that variability, I think the chances that the baby will come to harm is pretty small. I take Diogo's point that there is a diminished look to the variability towards the end. But if that reduction in variability is less than 4 minutes, many of those babies don't come to harm. In fact, I would expect this one to recover if the CTG was to carry on.
Right. I fully agree with you. Yeah. Yeah, definitely. So to sum up, excluding
Would agree that you stop pushing as
Yeah.
part of
exactly.
as part of the resuscitation. It's highly variable how often you see that in the recommendations. But if there should be, that should be number one in the certainly in the second stage of labor.
Actually, FIGO guidelines stresses that very well. it's part of the resuscitation.
That was Barry.
Oh, thank you, Barry, because it really makes a difference. And I think, and actually, clinicians are not used to do that. Normally, clinicians, just to try to give you another view, normally when we have this kind of tracing, clinicians try to rush the delivery as much as they can. So they increase oxytocin, they ask the mother to push more and more and more, and try to actually deliver the baby as quick as they can, which is something that actually increases the chance of the baby being born with an acidemia.
We are very short on time. We need to speed up. 2 questions, yes or no, quick answer, and we can move on. Is that a first baby? Sorry, I missed that. Is it
first
it's a
baby?
prima? Second question is, when you say stop pushing, is that physiologically always possible? Yes or no? Just really, can you know, there are situations where women can't stop.
It is normally when you have an epidural on, which is 90% of the cases in Portugal.
Can I just say that it's not possible to answer clinical questions by yes or no. That's possible in mathematics, but certainly not in clinic. If you want yes or no answer, I'm going to go back to my seat, and then my colleagues can.
Thank you, Austin. Thank you for saving us.
Consider the effect of having her push to outrace this fetal distress. Not only are you not going to outrace it, number one, you are going to increase the pressure in the head and limit the amount of perfusion in the fetal brain. So this push, rushing to get in response to quoted terminal deceleration is counterproductive.
Thank you, Barry. So oxytocin was stopped because it wasn't before. Salbutamol was put in, and
They keep pushing.
she kept pushing. Yes. So, okay. And she kept pushing, so the baby didn't recover. So what to do? Crash cesarean, instrumental vaginal delivery, give atosiban, ask mother to stop pushing. And
But notice there's no progress.
there is no progress. Yeah, exactly. That's what I was saying. The V was exactly the same.
Yeah, but it's only something like 10 minutes per pass. So
Yeah.
C here, V there, so
Yeah.
no progress in 10 minutes, I think.
10 minutes. Yeah. Austin, do you want to comment on that? Please.
Yeah, I think yes or no. Clearly, I think the persistence of loss of variability is a concern. I think it is true that the baby hasn't recovered, but it's actually making attempts at recovery, all of which have been unsuccessful. So what happens here will depend on the skill and expertise of the obstetrician. Doing a cesarean section in this scenario is not risk-free.
Exactly.
Yeah. So, sorry. Exactly. What
is risk-free?
Yes. Yes. What is? So,
True.
yeah. So for me, I go with interventions that have been implemented so far. Stop the pushing, stop the oxytocin, the tocolytic agent given, that's fine. But the loss of variability makes me want to intervene. And personally, I'll be doing an instrumental vaginal delivery.
Yeah.
Because that's quicker. In the appropriate hands, that's probably safer as well. If you're opting to do a cesarean, you could easily add another 5-10 minutes to preparation to do one, and to dig this baby's head out of the, scoop it out of the, that can be a challenge. So
Yeah.
if the baby is already sort of compromised, the trauma of the delivery itself can exacerbate that situation and make the problem worse for Anna.
Right. I agree with you. Anna, do you want to?
Anna's waiting for the baby to come
Yeah,
out.
yeah, yeah.
For the baby.
I'm seeing Annie very anxious to receive this baby. Okay, so at this stage, mother stop pushing.
Can I just make a point?
Yeah.
It's very
Sorry.
very fast. I think it's the what we can learn from this case is that you really need to stop the oxytocin before, because if you stop it later and you wait another 3 minutes and then you get salbutamol or terbutaline and you wait another 2 or 3 minutes, you end up with a 12-minute deceleration where you think that there may be some risk. And if you get the reduced variability, then you know there is risk. So you're really thinking now you have to do something. If you acted before and stopped it before, given the terbutaline a little bit before, it would have been a much calmer delivery.
Sure.
Yeah.
And what I think
That is true, except that they're working in real time. So, as I said before, even when the fetal heart rate collapsed there, given what it looked like before, I would normally expect that baby to recover. So I'll be doing the sort of basic things first, rather than charging to.
But don't you tell your midwives 3 minutes of a deceleration, there's oxytocin, stop it. That's what we tell our midwives.
My midwives don't listen to me. So.
But they are trained to stop oxytocin
So,
before they go to
They
you.
don't listen.
no.
Okay, so let's move on. But yeah, I totally agree, and that's why. But I think people didn't do it before because they were actually not recording quite well contractions and were quite relaxed. There was no
Too relaxed.
excessive contractions going on. So there was a normal vaginal delivery, normal weight, across normal. What do you think about P cases?
I think the gases will be relatively low, but I think it will be more of respiratory acidosis rather than metabolic.
Right.
In other words, if you look at the carbon dioxide tension, it's likely to be in double digits. Yeah.
Barry?
You mean between the arterial and venous?
Yeah, I would say so. Yeah.
Yeah, but
Because
I think most of it will be carbon dioxide accumulation. Yes.
Diogo?
Yeah,
you know the
I know the
Anna?
outcomes.
Okay. So these are the blood cases.
Yeah.
Years old, BMI, borderline BMI, first baby. Labor started with cephalic presentation, spontaneous onset of labor, epidural was put on by indication for monitoring. That's why this baby was monitored continuously. And there was a forceps delivery for prolonged labor. Let's look at, this is the most important aspects of labor, and we are now going to see all the trace.
Sorry, Ines.
Yeah, sorry, yeah. Desculpe, precisávamos de mudar. Sim. And we can just, yeah.
You want to tell me stop if you want to continue with the trace and then just tell me you want to stop.
Yeah. Okay.
It's okay.
Thank you. So this is
So Ines, the 3.7
was after the baby was born.
right, okay.
But
Okay.
Everything was like
So the
together
baby's
to
fine.
be.
So what are we doing here?
Yeah.
We don't know if the baby was fine.
Oh no.
This is antepartum, and well, only the final weight is in there.
Okay, but the forceps. Sure. Let's,
Yeah. So okay, just can you stop this? Right. So this is fetal heart rate. This is maternal heart rate, and these are the contractions, very beautifully depicted here. This is 1 centimeter per minute.
roughly.
Not roughly.
I don't-
You know, they might have
Yeah.
you don't have to take that.
Oh, okay.
It's a half an hour.
Okay.
So, for the time being, I think everyone is happy with this baby.
Yeah.
Austin, are you happy? Yeah. You're never happy. Okay. So baseline 120, 115, 120. So according to gestational age, yeah. Right. So and this is accelerations. Yeah, sorry. Yeah.
Well, most of it is cyclic.
Yeah. So baby is cycling,
Yeah.
which I think is very reassuring. Okay.
Sorry,
Yeah.
But the baby was cycling.
Baby was cycling.
That was
so
reassuring.
reassuring pattern. Yes, please. Yes. So let's stop here. Here, everything's fine.
Is this
Yeah.
external monitoring?
This is external one.
External monitoring. So that could be some contamination from the mother that period there.
Well, the green is the return.
Yeah, there is.
Oh, yeah,
Yeah,
a bit
there
of
is
signal loss. Okay.
signal loss. In both. Yeah, in both. Maybe in both. Okay, let's move on. Here, maybe I don't know.
Can you just
Yeah,
go?
sure.
Can you just go back to the area that Diogo just point?
Here.
Yes. So one of the ways I tend to look at what's going on there is if the maternal heart rate is contaminating the fetal heart rate at that point, the machine will focus on one heart rate, so there'll be a gap in the other one.
Yeah.
Yeah.
You just wasn't seeing the green.
Right. Okay.
Right. Yeah, it's true. It's true.
Yeah.
There's a lot of signal loss.
Okay, so let's stop here. The contractions, the pattern is a bit different. Don't you think so?
Half an
Which-
hour.
This is Toko.
Taco.
So
So,
The Toko setting is very, it's either too sensitive or something because you get this gigantic
Yeah.
contract. Yeah. But it is what it is. The fetal heart rate is normal, so I won't worry too much
Yeah.
about it.
right. Let's move on, please. Okay. So here maybe there is a change. Diogo?
no, I think there's one deceleration. It looks like a rate. The rate is going up. No,
That's the rate
it's 120. So
It's 120, but we started at 115, 110, 115.
nothing.
So there's a change, but it's an insignificant change.
Yeah, but it's not.
no information about oxytocin. Sorry, I don't know if it was used or not used.
The start of labor was spontaneous. We don't know if there was accelerating or not.
I do imagine.
I don't think.
Yeah,
They would have, not they would have.
they would have. Yeah, I think so.
No, they didn't.
So clearly, contractions are not being monitored adequately here.
Well, they are at the end, but not in the beginning. Could I say that these are typical variable decelerations with normal variability in between, so they're not really worrying at all.
They actually happen very often in normal babies during delivery.
Can carry on till Christmas.
Can carry out to Christmas. Right.
Normal.
I think we can continue. Yeah. Okay. So here, what do you think? I mean, after this period of repetitive.
So this is 3 minutes. 2 minutes. 3 minutes.
Yeah.
Can I comment?
Yeah.
This variable dissolution is different from the last one because this is three-wave type. There is acceleration and deceleration. Acceleration. Such case is it's called compression. So
In
so
the
then,
pathogenesis.
yeah, in such case is this expected is this deceleration that's so deep and wide and so cautious about it. We need to sometimes is amino infusion. So is some
relieve the word.
amino infusion is one of the
Do you normally
therapy.
use it in?
Yeah, usually use.
Do you use it, Austin? No. I know you don't. But
Sorry.
Yeah, we don't use it. We
How
don't.
often does it work? Working with amnion fusion, where you're trying to refloat the baby, refloat the umbilical cord, is sometimes very dramatic, but at least as often in my experience, it doesn't make a difference.
Yeah, I would say that if it was a worrying variable, I mean, if it was a more deep and large variable and more repetitive, maybe amnio infusion could do something. But these are really very short distance, and so for us, we just not take any notice of these variable decelerations.
What about dilations?
I don't know.
Yeah, I don't know.
It's up to the so
We don't know. No information. I don't know.
Particularly because it's such normal variability in between the decelerations, and because you have acceleration. So if you take out the decelerations, it looks like a normal tracing. They're very short decelerations. So no, I think we just carry on.
It's up to the stage of the delivery. If maybe the 3 centimeter, 2 centimeter, the amnion infusion is the one
To get rid of the deceleration.
But the 6 centimeter, 8 centimeter, this is also okay. But this,
Yeah, wouldn't make a
Up to the
difference.
stage.
Yeah, exactly. All right, let's move on.
Because these are the ones you really, I mean, with these, that they are very typical of the compression, aren't they? With the shouldering.
Sure.
So if you get a lot of these, maybe you start getting worried, or some people get worried and start thinking of amnio infusion. But before, they're really not very long.
Okay, we should continue, please. It seems like contractions are being registered other way around, upside down.
But either way, there's not very much time
Yeah.
between them.
It's one.
I mean, if look at the first one.
Yeah.
It goes from one to the other.
Everyone's happy with the tracing
Yeah.
so far?
Not too bad.
Okay, let's continue.
That's,
Yeah, maybe we
Too
can.
many contractions.
Everyone, every 3 minutes, remember? But 3 minutes, 3 minutes, 3
It's
minutes.
two
Yeah.
to three contractions in 10 minutes.
There's no
2 to 3. Yeah.
No, if you go a
2 to
couple
3.
earlier, it's couple.
So 2 to 3 in 10 minutes is really.
It's okay. It's okay.
It's
Yeah.
the scale that gets us
Yeah,
sometimes.
that's why I keep on saying.
No,
Yeah.
but I was just looking at
At the decent,
right.
yeah.
So what you want to say is the reason time between them. The number is that, but they're wide. Is that what you're saying?
Yeah, no,
The time between.
just stop at any one of them and you'll see what I mean. Go to the left or, yeah, right there is the point I'm trying to make, is that it
Yeah.
comes down immediately.
Yeah, and immediately to, yeah. So maybe uterine contractions are actually increasing in
Because there's
frequency.
probably hypertonus.
Okay. All right. Let's move on, please. Okay. So here, Austin, do you want to comment here, please?
I'm still very happy, but I agree with Barry in terms of not necessarily the contraction frequency. That's not the issue, but it is the duration of those contractions. So if a mom is contracting 3 in 10, and each contraction is 45, 60 seconds, that baby is in a different state.
Right.
Compared to the one, those contractions are at least a minute and a half. That's a pretty long time to hold on a contraction. So, but I don't think the baby is troubled by it, because if he's troubled by it, something will happen to the baseline. But perhaps that's what we're witnessing at 15:58. What I'll be waiting for is to see.
If she's on oxytocin, you have too much.
Yes, and it is one of those things that us clinicians miss out on. We set up oxytocin and then we count the contraction frequency as though oxytocin influence is only in increasing the contraction.
Yeah.
Yes, but actually the amplitude of those contractions and the duration is equally.
Oxytocin toxicity is not especially measured by the frequency of contraction.
Yes.
Because what happens when you get, my favorite question to midwives and what have you, and programming for those of you who are programming contractions, what is it you want out of oxytocin? You want regular, consistent, evenly spaced uterine contractions, plenty of time between them, okay? That's what you want. The minute you start coupling, the minute you start getting prolonged, you are already in an area of oxytocin toxicity. The other thing is you may never exceed 5 or so contractions in 10 minutes, but oxytocin toxicity is associated not with an increase in the frequency as much as it is a rise in the tone. And that's what you're trying to avoid. And you're not going to see that with an external. You can infer it from coupling of contractions.
Okay, let's move on. Thank you. So, yeah, continues.
Prolapse. Somebody looking.
Okay, let's move on. For the sake of time. Yeah, speak out. Yeah, please. Yeah, okay. So now I think the pattern, yes, please. The pattern of dissolutions is a bit different.
Well, again, they are deeper, they are wider. Yeah. So at most they will just be qualifying for complicated variable decelerations. But the interdeceleration interval is still over a minute, and the variability between those is still normal.
Okay, so we're still.
Yeah, again, for people that do fetal blood sample, if you did one now, it will be completely normal. So this baby is in charge of this situation, is what I would say. And if the baby is not worried, I'm not going to be worried.
Okay, but you would stop oxytocin?
Well, yes, because the duration of those contractions is quite
right.
a lot.
Okay, Joe.
Yeah, is she progressing well? And yet, any information? No idea. That's fine. So definitely stopping oxytocin when you get this sort of pattern. And I agree with Austin that the variability is for us is reassuring. But what did I want to say when I interrupted you? I think if we keep on monitoring. I mean, I now remember what I wanted to say. When we started using stand, some of the people were still worried with this sort of pattern, and stand was a very useful way of reassuring that the baby was being well oxygenated. With the passage of time, you get used to this sort of tracing, and you don't really notice it anymore. So you cease to need stand. But I think if you want a further reassurance that the baby is doing well, stand or fetal blood sampling may actually help, and you'll learn from that.
Right.
And obviously Oxford were happy with it, but they
Yeah, they continued, and apparently, uterine contractions are there. But there is an increase in blood in baseline heart
Is there?
rate, don't you think so?
Yeah, or a little bit under.
Okay, we're not worried about it. Yes, please. For the sake of time.
I think we should.
Yeah.
Now there's an
Now I
increase.
think.
Now
I was just waiting you for the end of this last dissolution.
But then you lose your.
Yeah, you lose because you're right. Yeah, that's fine.
Before the dropout, was nobody concerned about late cells?
Seems no.
I didn't think
No.
they're late T cells. Do you think they're late?
Right before the dropout.
no, I think
This pattern here.
I think what you're doing is you're giving the morphological description of a late deceleration. In other words, what you're saying is the peak or the uterine contraction. Yes.
So onset, two minutes after the contraction.
Yes.
That's worrisome.
Yeah. No.
In my experience.
Yeah, that's what I'm trying to.
It's not your
No, but that's what I'm trying to correct. That when the real physiological late decelerations arise from impairment of gas transfer across the placenta, and those decelerations are not usually this sharp drop, sharp rise. They're usually almost U-shaped. That is when and only when the relationship with the contraction becomes relevant. If you follow variable decelerations, some of them will meet that criteria. In other words, the deceleration will kick in after the contraction. At other times, they coincide with the contractions, and at other times, they actually,
So you're saying you're not worried about
no,
late
The-
variables?
no, exactly,
Mm-hmm.
exactly.
Okay.
Yeah, no, that is true. We, as clinicians, we've made that error for decades because we've been told that decelerations that occur after contractions are a problem for the baby. What I'm saying is that's just the morphological appearance of those deceleration. The genuine late decelerations will not dive down and dive up quite quickly. They come as U-shaped, and you're not going to get it to this contraction, and then it skips the next contraction, because the gas transfer doesn't change at the placenta. Once a baby begins to get late deceleration, they will deal with this contraction, that contraction, the next contraction, and so on and so forth. So it's not something that babies can switch on and then switch off. That's why I wouldn't classify this one as late deceleration. But if you just look at it, it is late in the sense that it appeared after the contraction. But that's it doesn't carry the clinical meaning or physiological importance of that.
And even
He doesn't look convinced.
no,
You can talk to him and make him.
sure.
I'm personally concerned, one, about the high rate, the high baseline after recovery, or at the time of recovery, that first one, and the fact how long it takes baby to recover after the deceleration. That's over a minute to get back to basic. Some of those. Is that increased variability after the, or just
And it's normal variability.
Okay.
But that's the nature of variable decelerations. They're just, they're inconsistent in terms of their amplitude, their relationship with the contraction, the duration. So I agree with you. Some of them are longer than 1 minute, but most of them are not.
No, not. I wasn't even concerned with the duration of the deceleration itself.
Right.
I was focusing on the recovery.
The recovery.
So if your recovery is now 150,
Yes.
you are now 30 or 40 beats higher
Exactly.
Yes. No,
when you started.
Yeah.
That's not proper recovery.
I agree with that. My reassurance comes from the fact that the variability is still very good, and the interdeceleration interval is still.
Yeah.
Still,
So could we agree that we are a little bit more worried than we were before because the baseline has gone up
just a little bit, yeah.
and the amplitude and duration of the decelerations has gone up, has increased?
They're related.
But we're still pretty sure that the baby is coping well with the contractions and with the cord compression that's probably happening.
Correct.
So what it says, if you go with the FIGA guidelines, what it says is this is a suspicious tracing because there are repetitive decelerations, which is not normal. So if you do find a cause, and here oxytocin seems to be the cause, I don't know if it is or not, but if it is, then you should stop it now and not wait until it gets worse.
Right.
We are in the first stage of labor still.
No idea.
All right.
No idea.
I think we are at the end of first stage of labor.
You're going to have a problem with the second stage.
Exactly.
Well, maybe yes, but maybe no. We'll see.
Okay, let's move on, please.
I am not here to predict what's going to happen. I'm trying to tell you this is a story to be made, and that there is a clear relationship between the frequency of decelerations in the first stage and the likelihood that you will see them again in the second stage.
Absolutely.
Right,
And the
absolutely.
only advice is push gently because you're going
missing
to
out the tray.
likely establish.
Have a look at the tray. Then you can really move on. There's more to come.
Yes.
Mm-hmm.
So apparently they decided to carry on with management.
Quite rightly too.
What?
Quite rightly too.
Yeah.
You have toxicity, oxytocin.
And actually, there is a rise of the fetal heart rate baseline now. We started at 115. We are now 160 beats per minute.
And for some of those, there's no recovery before you go into the next
Yeah.
one. And so these are the features that at least I'm suggesting that are connoting the potential for you're not allowing the baby essentially to recover.
Right.
Well,
Diogo.
if I could stop, because
before.
that starts.
Yeah, here, sorry.
These are the ones that I think, it's obviously there's no strict difference between the variable and the latent. Sometimes one evolves into the other. But I think the fact that you're getting a slow recovery and slow, so this I think is a bit more worrying. I wouldn't say it's a lot worrying because then you have normal variability after. But those sort of morphologies I think are more worrying for me.
So I think I agree with that. Awesome. Yeah, I mean. All right, so I'm trying to.
And can I just share, because Barry is saying if you have decelerations in the first stage, you're likely to get in the second stage, which is true. We've seen the loss of that. But sometimes in the second stage, with the center of the head, perhaps because there ceases to be compression of the cord, all of a sudden the decelerations disappear. So sometimes it doesn't necessarily get worse. Sometimes it just gets better.
It really depends on the maternal pelvis and.
The other explanation is the head turns, because decelerations are far more common in posteriors than they are
in anteriors.
So the head comes down, it turns, and the deceleration disappears.
Right. Austin. Right. So I think we are now.
Now there are definitely too many contractions because they're about 5 in 10 minutes.
Yeah, we are almost.
Or maybe a bit more.
But notice the pattern, notice the rhythm of the contractions. Remember, the purpose and the objective of oxytocin stimulation is the dullest rhythm you can find. Absolute metronomic pacing of the uterus. Shorter intervals, longer intervals, that's already too much oxytocin. And the baseline's way up, 160.
So this is second stage of labor.
Is it second stage?
Yes, I think so. Yeah, yeah, because I think it ends to.
How do you know when second stage starts?
I don't know, but I think it is because of the time.
Oh.
The baby was born at 2
Okay.
something. We don't have exactly the time when it started, but I assume this is second stage labor.
Yeah. Could I just say something? Because I think these are the tracings in which Stan really helps. Because not all the decelerations have a similar morphology. Some of them look a little bit more worrying. Some of the times you really can't see the variability in between the decelerations. Sometimes you get this pattern of slowly going up. And if you do have Stan, and if that's reassuring, you just keep on monitoring and not intervening.
And there, yeah, I think the most important thing is the baseline. We here don't have any stable baseline. So I think.
But do we all agree that in terms of software and early warning system, you want your software to be raising an alert here so that the consultant can review, so that the doctor can be making the decision?
The thing is that normally, absolutely.
Sure.
And sometimes in a busy,
Yeah.
Because at the time you need to stop oxytocin, that's when you should have already.
Yeah,
and sometimes
that's when the
we
first
have,
alert should have been.
Yeah.
Yeah.
Yeah, exactly.
And when sometimes we have very, very busy labor wards. People are making many things at the time, and if there is an alert system, maybe people will just stop what they're doing and evaluate the tracing and take measures.
Baseline is a far worse finding than variable decelerations. Okay, that you have no definable baseline. The events are happening so quickly. Okay. You can't identify it. Yeah, that's not a baseline.
But that
Baseline is an interval of stable heart rate at one level. What's the baseline there? You want to take the average?
yeah.
Here, mother is pushing here.
That's the problem.
But
And
Barry,
this
what I was
is-
saying is that you have occasional periods when there is a stable baseline, and then after a while you stop having a stable baseline, and it comes back. So
But that's 160, 155.
you know, it's tachycardia, definitely.
What?
Yeah.
Sure.
Do you need a mathematical definition? Mathematical. Could you just put it back a little bit? Because I think there are periods where we all agree that's a stable baseline there. But the period that Barry was showing before, there's no stable baseline at all.
I was just
So
going a little bit.
you get it sometimes
faster
and you
so that
lose
we
it.
can-
The way we do it with Cisporto is we keep it at that, we keep it at that, when there is, you show it. When there isn't, you just assume that it carries on the same level.
What I thought was one of the forces for those. This is for the basal rate.
Yeah.
One of the great concepts for fetal monitor was this notion of the basal rate. Okay, basal rate is defined as in this case, the 120 with 110 with normal variability, and I believe it should be plotted for the whole labor. Okay, so you plot that, and now you can create a delta at any time, because it is the strangest physiologic notion that you're going to define the baseline of what the heart rate is now. That's not physiology. If I jump up and down and my heart rate goes up, nobody would call that baseline. No, but that's not baseline. It is calculated in the absence of a deceleration and in the absence of an acceleration. That's why you can get a basal rate at the beginning of labor before all of this starts. And then if you find, you need arbitrarily a minute. Is that what you use? What do you use? 2 minutes.
Yeah.
What are you using? No. you're going
So
to,
what?
no, during the deceleration? Yeah.
Well,
Yeah, reasonably.
it depicts.
The way we do it is we use this concept of the basal fetal heart rate. We don't actually show it because we think it's confusing for some clinicians, but it's there. And you can configure it to be seen. And if there are changes, we adapt the basal. We use the basal heart rate to adapt the baseline. So for instance, here there is no real baseline that you can identify. So we use the basal. I mean,
Here.
that would probably be the baseline there. But there are many segments where you don't see any. You can't definitely there. You can't see any baseline at all. So we just carry on with the previous baseline. That's the way we do it.
Well, yeah. And
Well, is there a better option? Is there a better option?
As an alert that says baseline.
Yeah, that's another option. Yeah, definitely.
Abstracting a baseline from X minutes ago.
It's true, but it's the only way you can actually still identify accelerations and decelerations. If you just say, and if you find that's useful, well, here it probably doesn't make a lot of difference, but here, to identify these decelerations, it may be useful. To come up with alerts saying, repetitive variable decelerations or something. If we don't have the baseline, we can't calculate them.
yes, please, because we really need to finish in 5 minutes, and I would like to show
I don't
Anna's.
even know the outcome yet.
We need to show Anna's. Yeah. Sorry. Very quick.
I understand you have this 120 baseline. Would you decide to upgrade the or to change the baseline here? Would you make a decision to change the baseline to a new value or not?
If baseline is.
Yeah, I was just seeing for myself.
No, if we don't have an identifiable baseline according to the specific criteria, we won't. We would just carry on with the basal heart rate as before.
But I think there are two main messages here. One is the baseline shift from the beginning of the tracing until now, and the other one is the unstable baseline, or the in this stage. So yeah, probably here now. Oh my God! I don't know what I did.
Are we back to the beginning?
Anyway, why don't you present the outcome?
I would like to.
Show that last minute, please.
Only you uses this.
Well,
I'm
yeah,
sorry, Antonia.
okay.
Nobody uses this.
Deja vu. It's a deja vu.
Yeah.
That's fine.
That's why we show it on MATLAB. It's too long to be exported by any software. There's no other way to show it.
Just put that last three.
I'm trying to. Almost there.
We're almost there.
Yeah,
Yeah,
nice.
just 1 minute. Yeah. We do have over there. Vamos ter que rolar depois em casa em 2 segundos. Mas quando eu disser, não é já vais. Okay, so here we are. So after a very unstable baseline, we finally have a stable baseline. Okay.
It's not just unstable. There are lots and lots of decelerations.
Not a baseline. I agree with that. Not a baseline. Sorry. Disagreement in the room. That's fine.
Yeah.
Part of it.
It is. The problem is that we don't have much time to continue discussing this. I'm sorry about that. So if we,
But we're
Diogo, can you please just in
We're coming
1
to
minute?
the crucial point.
Yes, I know. So okay. So here,
What I was saying is just before it changes the pattern, it goes have a very severe tachycardia and reduced variability. There's a period of many decelerations before, and that's why, from our point of view, we need to keep the baseline. Otherwise, we don't identify those repetitive decelerations before. I'm not going to touch it, but just before there were lots of decelerations, and then it changed the pattern to reduce variability, tachycardia. I don't know if you agree with that, Austin.
What is that, 180, 170?
It's 170, 180.
This is the perfect horn sequence of normal CTG decelerations, increase in baseline heart rate, and then loss of variability. But I think the segment where we were debating the stability of the baseline, I think there was coincidence of maternal and fetal heart in that sequence. What went on there is pretty difficult to be certain. But if I may just return briefly to stable baseline or no stable baseline, I think once you have accelerations and or decelerations, by definition, it's impossible to continue to maintain this case about stable baseline. When I use the terminology stable baseline, what I'm actually thinking of is a long-term feature. In other words, the baseline is almost wave-like. And, I see it more often in babies that have had problems, antenatally. It was on some of the CTGs I have, but I didn't get a chance to show it. But these ones where there are repetitive decelerations, of course, if you have deceleration, you will struggle to find a baseline. If that baby is coping with the situation, it probably doesn't matter. And, our technical guys don't need to worry about it. I think they need to worry about the ones where the labor is not kicked in yet, and the CTG is almost a sine wave. I think for me, that's what makes more meaning if we're talking about unstable baseline than begin to focus on decelerations that occur in most of our labors. For me, that's really where the action is. This one is the baby is dealing with it. The baby cannot deal with it. So I accept that the terminology is widely used, but in certain contexts, it loses its meaning. And I think it's most meaningful for those babies that, you look at it and it's like a sine wave. Yeah. That's the thing that should worry us. Not, it's entertaining, it's academic, but I don't think it serves the purpose.
Yeah. But actually, Barry was not saying the expression unstable. He was saying that it's undefinable.
Undefined, yeah.
Yeah,
Unstable is you can define it. You can define it, and it's just not holding its own.
Not being
But
able
yeah, but
to see.
that's what Patrice is after.
It's a description of something that you can't define one rate, but
Yes.
at least you can see what it is between contractions. Indefinable rate is either it doesn't spend enough time at a given rate to be able to define a length of time of a consistent, stable, horizontal rate.
Shall we see the outcome, please?
Quickly say what do you think is the outcome of this?
Yes. What do you think?
And then we move to the end.
So you have
This
no,
is the
you have to tell me what
guys,
time.
please. Let me just say something.
Tell me what time the baby was born, and then I can tell you from the last time I saw the video happen.
15.
312.
312.
4 sets. There was a 4 sets delivery.
There's a
It
first,
was.
so
We
baby,
saw it before. Yeah.
so
Right, put on the slide.
so
Let me just say something, please. Sorry about that. We have exactly 5 minutes to finish this table because we'll have 11 taxis out there waiting for us to go to the boat. Otherwise, we will lose the boat.
Okay.
Sorry about that.
So who?
But we do have because
so shall we go now?
No. Sorry, can I switch the?
You're good. Let's
It's
go.
at 7. It's written down in the.
Do we need an hour and 30 minutes to get to dinner?
Because it's traffic time.
So we don't have a court gases, do we?
So we don't have cord gases.
Yeah.
These are the neonatal. Anna, please, can you please?
So I'm sorry that the court gases are not on the screen, but we had rather normal court gases and the upper. Well, no, that's the gases at 1 hour of age.
This is neonatal. There's perinatal.
Yeah, this one.
But there is the baby.
That's it. Sure. So baby was born with a nickel cord. Outbursts were 3, 6, and 8, and these are the cord gases, arterial and venous cord gases. The baby needed resuscitation, had 1 minute of bagging, and then had spontaneous breathing, and they were hypothonic, but well enough not to be admitted in the first instance. However, an hour later, which is unusual timing, I think. Want to go to the next one? Yep. The baby started having focal seizures, so left-sided clonic seizures, and therefore it was categorized as SARNAT2, but the baby was not, was hypotonic, but not overtly allopathic. It's the gas at 1 hour of age, and the lactate as well. The background EEG was normal in terms of the background trace, but there were seizures. Oh, sorry? That's day one. That's on admission, first hours of life. Although the criteria for cooling could be discussed, the team decided to cool this baby, and the baby had protracted seizures that needed 2 anti-epileptic drugs. And the MRI pattern showed multifocal hypoxic ischemic lesions, and the radiologist actually commented on the potential mechanism of injury with prolonged partial hypoxia ischemia. I think another etiology could be maybe multifocal stroke, I think, given the early onset of seizures, but I'm open to questions and discussion.
The baby suffers on that fetal monitor, suffers essentially an acute ischemic event involving its brain. It is injured on the basis of the tracing. The sequence of changes, the decelerations, the rising baseline, the loss of variability, the stable heart rate. At the end, that heart rate's what, 180?
Yeah.
180. It is higher by 70 beats over the time of this labor. Okay? And that is the pattern I showed you earlier. That is essentially the pattern of injury.
If it was a stroke, or if there was, all this sort of subacute hypoxia at the end, wouldn't you see more information in the MRI?
Yeah, so it's not a typical stroke. I'm not saying that. I'm just saying that it's not. I don't think it's either a typical kind of prolonged partial feature. I mean, a mechanism, because the timing of the seizures is quite unusual, I think, to me. What I'm
It was the first one. This one hadn't.
There's no basal ganglia
No,
involved.
no,
Isn't that
basal
right?
ganglia
So
injury. There's moderate
is-
watershed injury.
This is watershed, peripheral, prolonged partial, whatever you want to call it. And in
So it's
all
not
fairness, it's on the tracing.
Okay. So you do see a story here.
I'm not, for me, I would love to hear another explanation of this sequence.
Okay.
And if you're willing to time it, it is implausible that this baby was injured at the onset of this labor. And we see for how long this baby is resilient. And at the end, there's simply too many contractions, too much pushing, contract closer together, heart rate's going up, deceleration's getting deep, this variability is disappearing, and all of a sudden at the very end we're now 180 flat, and you can see the change in the pattern.
So timing is hours before delivery. So
No, the timing of the injury is probably, I wasn't keeping track of the time, but it's probably that threshold effect. And when Diogo pointed out this is different, that is probably when you're allowed to say it is already injured. So I don't know when it got injured, but you now have a point to look back and say you are now injured.
And what do you make of the core gases?
Yeah, it's not relevant.
Not relevant. Okay.
Well, so exactly, if we accept that this is a partial prolonged asphyxia, then those gases will make sense. But no, the gases don't change dramatically. So I think what Barry is saying, I agree with what Barry is saying up to a point. If the duration of those contractions have been such that there was little time for the baby to recover before the next contraction, then they'll end up with time periods judged to be at least 1 hour where there are repetitive episodes of hypotension. That's actually what seemed to correlate with, the pattern of injury that we're seeing. The question is, if you look at that CTG, can you draw the same conclusion? And the literature is split down the middle. There's actually, you must know about this, there's a chap called Clapp that made this suggestion that it is possible to inflict those injuries, but without necessarily altering the gases. And that may be what we're dealing with. So for my technical guys, you can now see how the sort of insecure world that we live in, where you think dinner.
Thank you so much. I'm really sorry we couldn't do better than this. Thank you. Thank you very much for your